Good morning, everyone. Before starting the class, I'd like to give instruction to the students. During the class, if at all a question is asked, I'll just unmute randomly any one of you. If you know the answer, kindly answer. Otherwise, you tell you do not know the answer so that I can go to the next person, or any one of you can raise your hand so that we shall have an interactive session. So today, for the next couple of days, today and Friday, I'll be discussing on penicillin, the first antibacterial drug to be found, discovered. Incidentally, till today, that is one of the most safest antimicrobial agent among all the available in the market. Now, before starting with the penicillin, just to give a brief introduction on this antimicrobial drugs. In the last previous two classes, introduction on chemotherapy. This, in pharmacology, there are hardly few drugs where you can have a complete cure. Most of the drugs, what we already come across, they are only have symptomatic relief. They are only controlling the disease, like for example, antihypertensives, anti-diabetics, drugs used in asthma, etc. There are few drugs where we have a complete cure. One such drug is antimicrobial drugs. This has revolutionized medical practice. See, hardly there are some drugs which we call as blockbusters. So antimicrobial drugs is one such drug. Similarly, anesthetics. Without anesthetics, there have been no surgeries. So very important group of drugs. And in a day-to-day practice, I think analgesics, next to analgesics, antimicrobial drugs are the most commonly prescribed drugs. The success of the practitioner, doctor, it entirely depends upon how good in using analgesics and antimicrobial agents. Not only from the practice point of view, even in your exams, if you see your paper 2, nearly 40% of the marks come from antimicrobial agents. So with this, I emphasize to all the students to give a little more importance to these antimicrobial agents. Even if you spend more time, nothing goes waste with regard to this topic. So today the learning objectives will be the history, brief history, classification of penicillins. Today I'll be only dealing with natural penicillins. Friday class I'll be talking about semi-synthetic. Structure and properties of penicillin, mechanism of action, kinetics of penicillin, resistance development, antibacterial spectrum, uses and adverse effects. Coming to the history of penicillin, Alexander Fleming, nobody can forget this picture. He was the person who discovered penicillin in the year 1928. He was a microbiologist. This discovery of penicillin was an accidental discovery. In fact, some of the drugs in pharmacology are all due to serendipity. That is serendipitous discovery, that is accidental discovery. While working on a staphylococcal culture, it happened due to some work. He could not return to his lab for a few days, and the lab window was open. And to his surprise, when he returned to his lab after 1 week, he happened to see there is a growth of fungus mold on the culture plate, and he also saw there is destruction of the staphylococcus colony. Immediately what struck to his mind is there is some chemical that is released from this mold that is responsible in killing this bacteria. Only thing, he was not a very good orator. Somehow he could not convince these other scientists and colleagues. So there was a dormant period from 1928 till almost 1939, where further progress did not happen in isolating this particular chemical. Only in 1939, two more scientists, Chain and Foray, followed up this study. They were success in isolating this penicillin pure form. During that time, lot of death used to occur due to this infection, septicemia. That was the period of World War II. Many soldiers were losing their life because of infection. Nearly, it is said, nearly 10 to 15% of mortality rate was reduced by this drug penicillin. You can see in that picture, thanks to penicillin, he will come home. So to that extent, it was a useful drug, penicillin. Similarly, there were other drugs, few of drugs I like to mention their discovery also. Sulfonamides. The person Paul Ehrlich, he is called as father of chemotherapy. Before pre-Ehrlich period, we call, the treatment was empirical, only through guesswork. Only during Paul Ehrlich, he was also a microbiologist who was working with various dyes for staining the microorganisms. That time he was using with methylene blue, trypan red. What idea struck to his mind is, when these dyes are able to selectively stain the microorganism, why can't they also kill? That's how he was successful in using trypan red, methylene blue in treating some of the infections during that time. Later on, similarly, Domag, another person in 1935, used rontosil dye, which is nothing but it contains a sulfonamide component. In fact, he was very successful in treating his own daughter of septicemia by using the rontosil dye. The other persons like Waxman in discovering streptomycin, and Subbarao, Indian scientist, was successful in discovering penicillin. Now coming to the classification of drugs, very important. We have natural and semi-synthetic. Natural penicillins are benzyl penicillin, also called penicillin G. The G stands for gold standard. Don't worry about the letters G, V, and penicillin G, which is benzyl penicillin, procaine penicillin, benzathine penicillin, and penicillin V. Penicillin V, I think it is orally stable, acid resistant. During the culture, phenylacetic acid, if it is added to the culture, it gives rise to penicillin G. If it is phenoxyacetic acid added to the culture, it gives rise to penicillin V, which is acid resistant. Semi-synthetic penicillins are those which I will be taking in Friday's class. They are penicillinase resistant penicillins, extended spectrum penicillins. Again, extended spectrum, we have amino penicillins, uropenicillins, carboxypenicillins, and beta-lactams inhibitors. The drugs names I will be putting up in my next class. Today you just concentrate on this natural penicillins. Coming to the structure and chemistry of penicillin. They are called as beta-lactam antibiotics. 4 groups of drugs come under this beta-lactam antibiotics: penicillins, cephalosporins, carbapenems, and monobactams. What you can observe in this chemical structure, that square ring, that is called as beta-lactam ring. You can see in the same square beta-lactam ring in all 4 structures. Here in penicillin, the other ring what you see is thiazolidine ring which has been fused with a beta-lactam ring. In case of cephalosporin, it is a benzene ring which is fused. Here also thiazolidine in carbapenem, only thing the S atom is missing. In monobactams, it is only single beta-lactam ring. You can see here in this the nucleus of penicillin. What is the nucleus of penicillin is? Thiazolidine ring with a beta-lactam ring and a side chain, R1 side chain. This particular nucleus is called 6-amino penicillinic acid. 6-amino penicillinic acid. By attachment of this side chain, you get various semi-synthetic penicillins. Where this side, how it is side chain attached by using this enzyme amidase. Amidase is the enzyme which splits this bond with the amino group, and here we attach various substitutions and get many semi-synthetic penicillins. In natural penicillin, here the group what is attached is benzyl. The other substitution which when we take next class, you can see there what are the other substitutions in the semi-synthetic penicillins. Now another important thing in this structure what you should note down is the biological activity, that is antimicrobial activity, lies in this structure beta-lactam ring. The integrity of this beta-lactam ring. So in fact microorganisms when they obtain resistance to these drugs, how they obtain is one of the ways by opening up this beta-lactam ring by releasing the enzyme beta-lactamase, also called as penicillinase. In case of cephalosporin we call as cephalosporinase. Broad we can all put together we call as beta-lactamase enzymes which are released by the bacteria and which they open up. When this bond is open, the drug is useless. It loses the biological activity. This thiazolidine ring here in carboxy terminus, we attach many salts, sodium, potassium or other groups, which makes the drug more aqueous solubility. The kinetics changes with the attachment of groups of this carboxy terminus. It's more of kinetic property. It helps in the movement of the drug. Whereas biological activity resides in this beta-lactam ring. So that's how this one thing you have to remember with regard to chemical structure. Now coming to the mechanism of drug action, I want students to concentrate on this particular diagram because this diagram is going to help you in almost all the drugs in future, antibacterial drugs. This diagram you can produce for any question asked on this chemotherapy. You can produce this simple diagram. What you can see here is cell wall, cell membrane, cytoplasm. Inside cytoplasm you can see the DNA, RNA and ribosomes where the translation of protein synthesis occurs. So here you can see drugs acting on cell wall synthesis like penicillins, cephalosporins, carbapenems and monobactams. And on protein synthesis, drugs which act on, that is 30, again in protein synthesis, there are 30S ribosome and 50S ribosome. Drugs acting through 30S ribosome is aminoglycosides and tetracyclines. Through 50S ribosome is macrolides, that is erythromycin, clarithrol, roxithrol, and another group of drugs is chloramphenicol. Through DNA, drugs that act by inhibiting DNA synthesis, a major group called fluoroquinolones. Whereas inhibiting RNA polymerase, RNA is rifampicin. Sulfamates act by inhibiting intermediary metabolism, that is folinic acid synthesis, active form of folic acid, that is inhibited by two drugs. One is trimethoprim, another is sulfonamides. They can see in the sequential blockade manner. And drugs that damage the cell membrane, like antifungal agents, azole antifungal agents, amphotericin B, they damage the cell membrane, make the cell membrane leaky. So all the cellular components get leaked out. So this entire diagram, what you see this picture, will tell you almost how most of the antibacterial drugs interact. Subsequent to this diagram, you can produce other diagrams with respect to the drugs whatever been asked in the exam. If it is a penicillin, after showing this diagram, you can show the cell wall synthesis, how it is inhibited, which I will be showing you. So because why I insist students to for diagram is, instead of writing big paragraph, this gives a very good impression during the evaluation of your paper, and getting good marks whenever the answers are written in diagrams, flow charts, and writing in points. Coming to the mechanism of action, beta-lactam antibiotics, penicillin, they act by inhibiting cell wall synthesis. Why this group of drugs is so safe? Even if you give 100 times the dose, the therapeutic dose, 100 times the therapeutic dose, nothing happens, no serious organ damage occurs in the host, only it affects the microorganism because of the selective action. The cell wall is not seen in our host cells, human cells, mammals. It's very specific to the bacteria. It is made up of thick layer, made up of 50 layers. What is the chemical nature of this cell wall? Is made up of peptidoglycan strands. It is the peptidoglycan strands and N-acetylglucosamine alternated with N-acetylmuramic acid, and this strands is interconnected, cross-linked by a pentapeptide, 5 amino acids. This is where the students have to clearly concentrate how exactly how penetrates. And if there is no cross-linking, the cell wall loses its integrity. So cross-linking is very important for the integrity of the cell wall. How this cross-linking occurs? It is by the action of the enzyme transpeptidase, what we call as penicillin binding protein, because that is the place where the penicillin comes and binds. By binding, subsequent it inhibits that action of that enzyme. So this transpeptidase is the enzyme which is very important for this cross-linking. What exactly it happens is, this transpeptidase enzyme, it causes cleavage of the terminal amino acid of the pentapeptide. That is the name of the amino acid is D-alanine. By causing cleavage, the energy is so released by opening the bond. That energy is utilized in cross-linking, for cross-linking of the opposite neighboring strands. So energy is so released by cleavage of the terminal amino acid. The energy so released is used for cross-linking with the neighboring strands. Now what does penicillin do? Penicillin, it inhibits this enzyme transpeptidase. It chemically, the structure of penicillin, it resembles the D-alanine, structural analog to the D-alanine of the pentapeptide. So instead of D-alanine, this penicillin goes and binds to the enzyme, to the active site of the transpeptidase enzyme, and prevents that cleavage, that reaction. So there is no energy release, so no cleavage, no energy release, so there is no cross-linking. So without cross-linking, the cell wall is destroyed, and what happens is, once the cell wall is damaged, since inside of the bacteria is highly hyperosmolar, because being hyperosmolar, water gets into the bacterial cell, there is swelling, and ultimately it bursts. Completely bactericidal action. So I will repeat here with regard to mechanism. So first thing what you write in mechanism, first step is, penicillin, after entering into the bacteria, it goes and binds to the particular penicillin binding protein, which is nothing but transpeptidase enzyme. That is a very first step. Subsequent to binding, it inhibits the catalytic reaction, that is cross-linking. So because of this, cell wall gets damaged, there is water leaks into the bacterial cell, there is swelling of the bacteria, and ultimately burst completely in bactericidal action. Apart from that, there is one more enzyme called autolysin enzyme that is also released, and this enzyme released from the bacteria whenever there is any damage, anything wrong going on, this enzyme is released, and that this enzyme will further damage the remnant cell wall. So that is an additional mechanism. Now when I told bactericidal, now I want to ask one question. There is one more actually bacteriostatic. What is the importance of knowing this bacteriostatic or bactericidal with regard to the clinical application? I like to ask Abhinav Vasan. I like to unmute. Can you just tell the answer? Are you able to hear me? Or anyone who can answer this question, what is the importance of bactericidal and bacteriostatic with regard to the clinical application? Raise your hand.
The back.
I'm not able to hear. Santosh? Your question ಕೇಳಿದ್ನಿ ಏನು ಆನ್ಸರ್ ಯಾರು ಬರಲಿ ಯಾರಿಗೊಬ್ರು ಕ್ವಶನ್ ಕೇಳಿದ್ನಿ ಸಪೋಸ್ ನಿಮಗೆ ಕ್ವಶನ್ ಹೆಂಗೆ ಮಾಡಿ ಅವ್ರು ಮಾತಾಡಬೇಕು. Hello. So just continue with the class. There's some technical problem with regard to asking questions. The importance of bactericidal and bacteriostatic. See, what is the clinical importance of this is? Suppose when you're treating a serious infection, life-threatening infection, or immunocompromised patient, which drug you like to choose, a cidal or a static? It would be cidal. The reason is, in bactericidal type of activity, the drug completely kill the microorganism. Whereas in static, it only inhibits the growth. So, by inhibiting the growth, the ultimate fate of the microorganism will be taken care by your immune system, which will phagocytose and destroy. Whereas in Seidel, the drug itself does the entire job. So why do you prefer a Seidel in serious life-threatening infection? Because the infection is overwhelming, too much of organisms. Or in person who has immunocompromised, the immune system is not in a position to get rid of the microorganism. So you should go for a Seidel type of activity. So there is a clinical importance of this, knowing this bactericidal activity. Now coming to the kinetics of penicillin. What things you should know here in kinetics is this natural penicillin is acid labile, thermolabile. Acid labile means once, why you can't take it orally? Why penicillin is not, natural penicillin not given orally? Because the pH of the gastric juice 1.5 to 2, it will destroy the drug. So it is not given orally. Benzyl penicillin is not, why not given orally? Benzyl or procaine or benzythine is because of this. Whereas phenoxymethyl is acid resistant. Whereas these three penicillins, benzyl, benzathine and procaine, they are all acid labile. Thermolabile. Increased heat also will destroy. That's the reason penicillin, once they prepared, it should be kept in at 4 degrees. Otherwise, it loses the efficacy because of thermolabile. Penicillin is widely distributed mainly in extracellular. Plasma protein binding is to the extent of 60%. Here again I like to ask, with regard to plasma protein binding, if the drug is highly protein bound, what would be clinical implications? Suppose you are treating a serious life-threatening infection where you want immediate action. Do you prefer a drug which is highly protein bound or less protein bound? It would be less protein bound because you know the free plasma concentration will be more with the drug which is less plasma protein. Highly protein bound, it will be bound form. It will not be immediately, it will not be available for action. It will be there's a slow delay release for the free level to rise. So when you are expecting the action to be fast, you prefer a less protein bound. So that's the importance. Um, what are the other things about this distribution is penicillin do not cross the blood-brain barrier in a normal person, but when the meninges are inflamed, in case of meningitis, they cross. So one first students should not confuse why in meningitis penicillin is given in spite of they do not cross. During inflammation, they cross the blood-brain barrier. Coming to the elimination, penicillin has a very short half-life, the natural penicillin, only 30 minutes, because immediately they are excreted, eliminated through glomerular secretion. 10% is filtration, remaining 90% tubular secretion. By a process in the proximal tubule, there is one transporter called as OAT, organic anion transporter. You can inhibit this secretion by giving a drug called probenecid. Here again, I like to put a question to the student, very commonly asked in exam. Why probenecid is given along with penicillin? So to prolong, because the action of natural penicillin is very short, in order to prolong, when probenecid is given, the probenecid, by inhibiting the organic anion transporter in the proximal tubule, they inhibit the tubular secretion of penicillin, so that the action is prolonged. Same probenecid is used elsewhere. Can any of you tell me what is the exact another use of this drug probenecid? Probenecid you come across in the treatment of chronic gout, where it increases uric acid excretion. There, whatever uric acid is filtered in the glomerular filtration, it is once again reabsorbed by the same organic anion transporter It's a bidirectional transporter. One way penicillin is secreted into tubular lumen. Here, uric acid from the tubule, it is taken back into the bloodstream. So it's a bidirectional. There also probenazide, it inhibits this OAT, organic anion transporter, and uric acid is not reabsorbed. So whatever is filtered, it is getting excreted. That's the reason probenazide is called as uricosuric drug. So please remember, the question can come, this use of probenazide, why it is combined, what is given in case of doubt or in case of fear, you should have a clear idea, students. So what I said is that a water soluble, acid labile, thermal labile, and why it is given along with penicillin. Here in this slide you can see the kinetics of antibacterial effect. Another very important clinical application is there. Time dependent antibacterial activity and concentration dependent antibacterial activity. What is this time dependent killing? Here the time above the drug remains, the minimum inhibitor concentration gives the maximum effect. You know what is minimum inhibitor? That is the minimum concentration required for inhibiting the growth of bacteria. MBC is minimum bactericidal concentration. That is the minimum concentration required to completely kill the bacteria. Minimum inhibitor is the minimum concentration required to inhibit the growth of the visible growth of the bacteria. Okay. So always you select a drug which is having very least MIC minimum. That means to say the organism is highly sensitive for that particular drug. That's how you get the culture report in microbiology. Highly sensitive, moderate sensitive. When you say a drug is highly sensitive, means that is the least concentration required to kill the inhibit the growth of the bacteria. So in case of penicillin, the time above the plasma concentration is above MIC, it produces maximum effect. Suppose the here the dose interval should be properly maintained. Correct, the dose interval properly should be maintained. Otherwise, once if we miss the dose, the minimum inhibitor on the plasma concentration falls below MIC. Once it falls below MIC, what is the problem? The bacteria starts again multiplying. So you lose the efficacy. So many times the doctors may make mistake by not advising this. Whenever using penicillin, the timing should be properly taken. The frequency of administration should be properly maintained. And these drugs don't have that less post-antibiotic effect. What is this post-antibiotic effect is? Even though the drug is not there in plasma, still the antibacterial activity resides, will be there. So in other, next you can see in concentrate dependent killing, that's what aminoglycosides, fluoroquinolones have prolonged PAE, post-antibiotic effect. That is to say, once again repeat, even though the drug is not there in the plasma, still the antibacterial activity persists. Okay. Because whatever the mechanism in inhibiting the proteins and whatever it is, they are there. Like hit and run drugs, what you studied in omeprazole. Even though the omeprazole plasma half-life is only 3 hours, the anti-secretory action of omeprazole remains for 24 hours. You give only once a day. Hit and run drugs we call. That is, even though the drug is not there, the effect persists. Similarly here also, even though the drug is not there in the plasma, their effect persists. That is having longer post-antibiotic effect. In such drugs, here we in constant dependent killing. For example, I'll explain the example. Aminoglycosides, initially it was given twice a day, 80 mg twice a day. But today, present is we give entire dose, 80, 160 milligram once a day dosing. Because of this type of antibacterial effect, you get the effect, whatever maximum effect, by giving a single dose. Then why you want to give 2 doses? Always patient complaints will go down when you give drugs in multiple doses. So any drugs taking single is better, patient complaints better than giving multiple dosing. So when you are getting the effect, maximum effect by giving single, then you need not give 2 times. Another major advantage of giving in single dose of aminoglycoside is adverse effect. You know, aminoglycoside have a serious toxicity causing cochlear damage, hearing impairment. So that can be reduced by giving the drug single, because the ototoxicity of cochlear damage is directly related to the maximum time the cochlear cells exposed to the aminoglycosides. So by giving single dose, you can reduce the exposure of cochlear cells to the drug without compromising the efficacy. That is the idea. Please remember, this is a very important practical point. Why aminoglycosides preferably given single dose. Coming to the spectrum of activity, always students have difficulty in remembering the spectrum, because how to remember the names of like so many organisms. So only thing you can represent diagrammatically by putting a pie. This is a pie chart, 360-degree, showing that all microorganisms, gram positive cocci, gram negative cocci, gram positive cell, all the organisms. Yeah, you can show, what you can show is the dominant microorganisms, which is highly sensitive. That organism you can shade it and show, and enumerate few organisms if possible, and shade that part of microorganism, and you can show it's that the given drug is highly active on those particular organisms. Here you can see penicillin, natural penicillin is a narrow spectrum. The meaning of narrow spectrum is it doesn't act on all the microorganisms, only few. What are the few microorganisms? One is gram positive cocci, strepto, staphylo. Then in coming to the pneumococci, then gram negative cocci like gonococci, meningococci, gram positive bacilli, few bacilli like cornybacterium, clostridia, tetanus, clostridium tetanus, listeria, etc. Similarly, spirochetes, trichomonas pallidum. They are all highly sensitive organism. But now recently pneumococci, staphylococci, they have developed resistance, and few gonococci also developed resistance. This resistance I will discuss later on, how resistance has been developed by these organisms. Same thing here, the spectrum of activity, you can see what I told you in the pie chart. So pie chart gives a visual good impression. So that's the reason I put in that format. Same thing again, repetition. Which are the organisms they are sensitive to natural penicillin. Coming to the development of resistance, there are three major mechanisms by the resistance exhibited. Mechanism how it develops is what I think microbiology study, or in last previous class in introduction chemotherapy, you might have been told that mainly through gene transfer. There is gene mutation, gene transfer. Again in gene transfer, three mechanisms: conjugation, transduction, transformation. Conjugation, there is a direct link between the bacteria to filaments, sex filaments, through which the resistant gene is directly enters to another bacteria through that filament. Conjugation. In transduction, there is a in between mediator, bacteriophage, viral, that will take up the resistant gene from one vector to another. In transformation, the resistant gene is just left in the environment. From the environment, it gets into the next another microorganisms, and that's how the resistance is developed. In case of penicillin, the mechanism is gene transfer, mainly conjugation and transformation. There's a small video at the end, maybe not today's class, maybe next class. I will show you 7 minutes video about the mechanism as well as this development of resistance. Because once you see that, you will not forget. Okay. Now, how this, whatever the mechanism, the gene, resistant gene is transferred, ultimately how it is exhibited. Exhibition occurs by three mechanisms. One is drug restriction, modified binding site, and impermeability. In case of penicillin, the most common mechanism is drug restriction. I told in chemical structure, beta-lactam ring. So this enzyme penicillinase is liberated by the microorganism, which is going to break up this beta-lactam ring, and that's how resistance is developed. the organism more Staphylococcus aureus, they develop resistance through this mechanism. Whereas there is unknown mechanism which resistance also develops to penicillin is modified penicillin binding site. I told you after penicillin enters the bacteria, it binds to the target site, that is transbacterial enzyme, that is the penicillin binding protein. In resistant organism, what happens is the penicillin binding protein, the structure gets altered. So because of the alteration in the structure of the enzyme, the drug doesn't go and sit, doesn't go and bind to the catalytic site. So that is how another minor mechanism. The organism which develop such mechanism is pneumococci and methicillin resistant Staphylococcus aureus. Third mechanism, that is impermeability, that doesn't happen with beta lactamase commonly, particularly not with this gram positive cocci or bacilli. It happens with gram negative bacteria, particularly example for aminoglycosides, wherein the drug enters through certain channels, porine channels in the cell membrane entry. Okay. So even the bacteria develop resistance, these porine channels get altered, modified, so they don't allow the entry of the drug in the very first in place itself. The drug doesn't enter. Or even if it enters, there are certain proteins, efflux proteins. What the, as the name tells, efflux, opposite of influx, efflux, E-F-F-L-U. So they'll pump out whatever drug that entered, it will be pumped out. So that is another mechanism. This mechanism you can see in case of gram-negative bacteria for aminoglycosides. When I talk about drug resistance, I like to ask students. Now today major problem with multi-drug resistance. We don't have new molecules, antimicrobials coming in the market. Only thing is we have to protect the available antimicrobial agents. Why there's no new molecule coming is because there's no huge profit for the industries, so they are not risking in putting their money in finding new molecules. So what happens? What is the problem we are facing is when any antimicrobial agent is used repeatedly, naturally resistance develops. So only as doctors we should see that we should minimize this development of drug resistance. What are the methods we can minimize this? I think last class this would have been told again. One is you go for a highly sensitive drug. That's the reason how microbiology report is going to help you to select a drug which is highly sensitive. Just because in vitro the report shows highly sensitive doesn't mean they will be very useful clinically, because many times vitro highly sensitive. When used in patient, it may not give response because of the other kinetic problem like tissue penetrability, and other solubility issues and all. So good tissue penetration also important. Even though in vitro study shows very good sensitivity, if the drug is not have a good tissue penetration, the infection which somehow the infection in a remote location, it may not be properly cured. So all these things you should care. That's the reason in choice of antibiotic you should apply all these factors, drug factors, patient factors, organism factors, in coming to a conclusion of the choice of the drug. So here this is where your skill is very much, your knowledge and skill is important in choosing antibiotic microbial agent. Okay. One way is go for a selective, highly selective antimicrobial agent. Second is whenever you are treating a chronic infection like tuberculosis, where the treatment is prolonged, you go for combination therapy. Because one drug, if you use, what is the problem is, you would use for a very long period, and during that long period, the organism can become resistant. When you use multiple drugs, the duration is cut short. At the same time, the organism cannot develop resistance to all the drugs. That's what the typical reason why you use multiple drugs in tuberculosis. 5 drugs, 4 drugs in tuberculosis. Similarly, in HIV, leprosy, etc., H. pylori infection, all those things. Coming to the penicillin, natural penicillin, they are given in units. Students should know the conversion of how the units are. Benzyl penicillin, 1 unit of crystalline benzyl penicillin is equal to 0.6 microgram. 1 milligram is 1000 microgram. Okay, or else you can remember 1 gram, that is 1000 microgram, is equal to 1.6 million units. In India we use lakhs. Lakhs means 1.6 million means it's 16 lakhs. 1 million means 10 lakhs. So 1 gram is 16 lakhs or 1.6 million units. Sometimes million can be called mega unit. 1.6 mega unit or million unit. If you put in lakhs, it is 16 lakhs. Okay, so that conversion keep in mind. What are the preparations? Sodium penicillin is is water soluble, clear, crystalline. It can be given both IM or IV. Whereas repositive penicillin G are insoluble salts. Here again I like to students should remember never give procaine penicillin or benzathine penicillin IV. It has to be given only IM, capital right, only IM. See, some instances have happened where accidentally procaine penicillin have been given IV by nursing staff or doctor sometimes and result into death mortality. The reason is why? Why suspensions, insoluble salts cannot be given IV because of microembolism. Remember, okay. See that, be careful not to give this. First of all, the usage of natural penicillin has declined. The reason is these are known, rarely they produce anaphylaxis rates. Even though it's a rare, it's a life-threatening. So every time you have to give a test dose. Before administering natural penicillin, you have to give test dose. That is the reason it has lost the popularity. Now, there is a wonderful drug. The only problem with the usage of penicillin, you have to give a test dose before administering every time, each time, because a person who is allergic initially may not be showing allergic, or a person who is not allergic may become allergic in future. So that's the reason every time you give penicillin, you have to give a test dose, natural penicillin. That is the reason it has lost the popularity. Now we have better other semi-synthetic penicillin which can be used for similar uses. Coming to the users, most common use of penicillin is in treatment of streptococcal infections. Streptococcal infection leading to upper respiratory tract infection as well as lower upper respiratory tract infection like pharyngitis, tonsillitis, otitis media, meteor infection, subacute bacterial endocarditis, rheumatic fever, and lower respiratory tract infection like lobar pneumonia, meningococcal meningitis, then gonococci, which is one of the sexually transmitted disease. There it is one of the drug of choice. Ophthalmia neonatum in the newborn babies. Diphtheria, tetanus. In these two conditions, penicillin have an adjuvant role, because for diphtheria, tetanus, the effective treatment will be anti-diphtheric toxin or anti-tetanus toxin. And what is the role of antimicrobial agent is to reduce the carrier state. Okay. The other uses, rare uses of penicillin is anthrax. And the bacteria, particularly anthrax, is very dangerous if it goes to lungs. With actinomycosis, rat bite fever, etc. As a prophylaxis, penicillin is used in rheumatic fever and bacterial endocarditis. Rheumatic fever, we give a long-acting penicillin, that is benzathine penicillin. Okay, anyway, I'll be discussing later on. So, in subacute bacterial endocarditis, penicillin, sodium penicillin G is used 10 to 20 million units IV daily plus gentamicin. Alone penicillin may not have effect, cure. Gentamicin is aminoglycoside which is combined given with this penicillin. Nowadays, instead of penicillin G, we give ampicillin plus gentamicin for the same condition. Here, the synergistic action, drug synergism, where one drug enhances another. How aminoglycoside activity is enhanced by this penicillin is, penicillin, it destroys the cell wall so that the penetration of gentamicin becomes easier into the microorganism. So two different drugs acting through two different mechanisms, one enhancing the effect of another. So here we want an example for drug synergism. Penicillin plus gentamicin in treatment of subacute bacterial endocarditis. This particularly happens subacute bacterial people having some valvular disease who undergo any invasive treatment like catheterization or any dentistry, any tooth extraction or anything where bacteremia occurs. In a normal person, normal immunity, nothing, but in a person with valvular disease, this trivial bacteremia may end up in causing serious subacute bacterial endocarditis. In ophthalmic neonatal, local saline irrigation along with penicillin can be given. Syphilis, another sexually transmitted disease. Here also drug of choice. Penicillin is one of the drug of choice. till today. This organism trypanosomes shows highly sensitive for this penicillin. Okay. For early or latent syphilis, procaine penicillin is given 1.2 mega units intramuscular daily for 10 days, or benzathine penicillin 2.4 mega units weekly. Procaine penicillin is given daily. Benzathine can be given weekly for 4 weeks. For late syphilis, benzathine penicillin giving 2.4 mega units weekly for 4 weeks. In neurosyphilis or cardiovascular, initially you can go for short acting. There is sodium penicillin given 6th hourly for 2 weeks, again followed up with a above regimen, that is procaine for another benzathine cycle. Okay. One more in the preparation, I did not tell you, fortified penicillin, PP4, fortified penicillin we call us. What is fortified penicillin is 1 lakh unit is penicillin G, 3 lakh unit is procaine penicillin. So what is the idea is that 1 lakh unit penicillin G is gives immediate action, and 3 lakh unit of procaine penicillin gives a sustained action. So for immediate and sustained action, we give that combination called as fortified penicillin. Okay, fortified. It contains both penicillin G and procaine penicillin. So it already told you diphtheria and tetanus. What they have the role penicillin is only an adjuvant role. Main treatment is antitoxin. In rheumatic fever, as I told earlier, very important, benzathine penicillin is given as prophylactic, where this benzyl penicillin is slowly released from the intramuscular site, and that slow release will extend up to almost 4 weeks. So once injection given once in 4 weeks. How long? For 5 years or up to 18 years, whichever is more. The reason is, whenever a person is this bacteria, a person sensitive to this particular streptococcus infection, beta hemolytic streptococcus, if you don't treat, if you allow, these bacteria can colonize and can cause severe heart problem, valvular disease. So that is the reason this prophylaxis should be continued up to 5 years. Coming to the adverse effects, I already told you, penicillin is one of the safest drug. No serious organ damage. Even if you 100 times the regular dose, nothing happens to any organ, kidney, or nothing is damaged. But only problem is the allergic reaction. This allergic reaction can extend only 1% up to 10%. Most of the allergic reactions are mild to moderate. Serious one, that is anaphylaxis type 1 reaction, occurs 0.01. In other words, 1 in 10,000. Out of 10,000 patients, 1 patient or up to 4 patients out of 10,000 can get this anaphylaxis. That's what I mean, 0.01 to 0.04. 1 or 4 out of 10,000. That anaphylaxis. Most of the time, what allergic reaction are mild to moderate, self-limiting. What are the mild to moderate? Like rash, itching, urticaria. Rash, urticaria means raised. This one, it immediately subsides. Urticaria. It's a type of rash, bumpy rash. Okay. Urticaria, fever, wheezing, angionated edema, serum sickness. These are the less common. Okay. Anaphylaxis is rare. So that is the reason for because of anaphylaxis, always we have to give test dose, then only natural penicillin can be given, not without testing the drug. The anaphylactic reaction, it increases with procaine penicillin more compared to other natural penicillin. The reason is procaine itself is allergic. So there is a reason, if at all a question is asked, which penicillin is known to cause anaphylactic reaction, is procaine penicillin. Where a scratch test and intradermal test is performed. Remember, even these intradermal people, some people have even for intradermal test, they have shown severe reaction. Okay, so always you should have adrenaline at your hand, because if at all, unfortunately, a person collapses for a test dose also, you should be in a position to retrieve by giving the person adrenaline, because the major the mechanism for the anaphylactic is the sudden release of histamine that causes shock, anaphylactic shock. So immediately physiological antagonist would be adrenaline, which is a vasoconstrictor and raises the BP immediately, followed by other drugs which I will show next. So treatment is, in case an anaphylactic reaction occurs, the treatment would be adrenaline injection 0.5 milligram. You know, it comes in 1 in 1000. Every ml contains 1 milligram. 0.5 milligram is 0.5 ml. 1 ml. No, it comes in 1 ml ampule, 0.5 milligram. Then injection hydrocortisone, steroid 100 mg IV, stat. Then antihistaminic, older antihistaminic. Ketamine 20 milligram IV or IM can be given. It's a very important treatment for anaphylactic reaction. Out of the first drug, please remember that is a major life-saving drug. Even the other two drugs, if you don't give delay, no problem, but adrenaline should be immediately given. What are the other adverse? Super infection doesn't occur normally with penicillin because being narrow spectrum. Again, this is a very important short terms for students. Super or supra infection. What is supra infection? You may ask for writing for 5 marks. So this occurs because of using for long duration or broad spectrum antimicrobial agent, where the normal flora is disturbed. You know, you're aware that you need GIT, skin, urinary tract, mouth, everywhere there is normal flora, which gives protection from pathogenic organisms. Okay. So when this normal flora was also getting killed, eradicated, opportunistic infection, which are waiting for opportunity, they may invade and produce serious infection like Candida
The
albicans
gastric
infection,
reaction is when there's
prostate infection.
fever and myalgia seen in syphilitic patients injected with
This is
penicillin.
very less natural.
There's an increase in spirochetal lytic product
Next,
which causes the reaction. It's an example of
the other
hypersensitivity to
reaction that
penicillin.
may occur is with penicillin is Cherish eczema reaction. Similar to lepra reaction, this is a delayed hypersensitivity reaction. Here, what happens is after using, when you start treatment in a syphilis patient, when you start giving penicillin, after a few days, the lytic products released, when the bacteria is killed, the products released from the bacteria that can initiate a delayed hypersensitivity reaction, manifesting with fever, myalgia, arthralgia, and exacerbation of the lesions and all. Here, you may not stop the treatment. Remember, don't stop the treatment. The patient may be panic. He may think that because of the treatment, the condition worsened. You have to tell him beforehand such reaction can occur, that you will not stop the treatment. Only thing is assurance. Give NSAIDs like aspirin and sedation. That is enough. It's a self-limiting. Similar to Jarish eczema reaction, what you see in syphilis patient, similarly you can see in leprosy, lepromatous leprosy patient when you start with dapsone. Same thing, same mechanism. There also treatment remains same. What are the other side effects of penicillin is local irritation, pain at injection site because of irritant nature, thrombophlebitis when given IV. Neurotoxicity very rare, very high dose, that too in the renal failure, if you give high dose of penicillin, 20 mega units, 20 million or 200 lakh units, then something can occur rarely. Bleeding rarely because of inhibition of platelet activity. So thank you. So video, I had a video that I'll run maybe next class, Friday's class. After completing the semi-synthetic penicillins, where I'll show 7 minutes video is there. That's so it will be, you will not forget the mechanism and resistance. Okay, the assignment also will be given in the next class. Questions on this topic. Okay, before winding up, again I'll emphasize students, please read antimicrobial drugs is very important, both practice point of view, clinical point of view, and as well as your exam point of view. And penicillin is a very commonly asked question. If you see a question papers, many times this question have been asked, penicillin. Okay, with this I'll end up this class. Thank you for being patient with me.